And the reality is more like this, that actually it doesn't stop when you get a license. We all know this. There's a much more complicated process around getting access. So this is the section we're going to focus on today. Okay, so there are 3 different types of organisations asking 3 different types of questions. At least they have been to date. They're starting to come together a bit more. We have the regulators. So this is how you get your licence, basically saying, is it safe, does it work? We have your health technology assessment, where they're saying not just does it work at all, but how well does it work, and is it value for money? We have the NHS, asking both those questions, how effective is it value for money, but also is it affordable? Now those of you who've been following developments at NICE and NHS England will know that those questions are starting to come together, and the organisations all seem to be asking the same thing now. So why is it so hard to get access? What we heard a little bit from Mary Rose, that the drugs can be expensive. Is it that simple? Or is it just that it's an incredibly complicated process and we're trying to understand? Well, the reality is probably a bit of everything. A lot of drugs are not cost effective. Small patient populations and a large investment cost, you're always going to have higher prices. But actually one of the bigger challenges is the lack of evidence. So you all know that often when there's a new drug in a new disease area that perhaps hasn't had a licensed treatment before, and bearing in mind that for rare diseases about 95% of them do not have a licensed treatment, this is the majority of rare diseases. We find we don't know much about the natural history, we don't know much about the impact of the disease, the wider impact of the disease. We may have a short trial period, so we don't really know what's the benefit going to be in 10, 15 years. We're trying to extrapolate, we're trying to look at the data we've got and make quite big decisions and make big assumptions over a long time period. We're also trying to look at other elements of decision making, and this runs through pretty much all of the different processes. Societal value, the seriousness of the condition, the availability of alternative treatments, all these come into play. And decision makers are also asking other questions. I'm asking this for hearing this from the public, from politicians, but also asking themselves, is it right to fund very, very expensive technologies? Is it right to spend that much money on one individual? Should it be high price for rarity? And is it right to refuse to fund treatments if there's no alternative? Is it right to fund them if we're not sure, if we're very uncertain about the impact? And it's grappling with those questions that has led probably to an ever-increasing number of processes to get access, which I think is leaving probably everyone in this room, myself included, a little bit confused about where a treatment in your disease area would end up going and how access might work for you, your family, your patients. So UK decision making, this slide looks so simple, doesn't it? You've got your HTA agencies, health technology assessment, and your NHS payers or commissioners, and there's not that many names on the board on this slide. So that's great. It's still more than one, and wouldn't it be nice for rare diseases if we had a much simpler process for decision making? But this slide at least looks straightforward. I'm going to focus in on England, mainly because I know it best, but also because it seems to be the most complicated, and there's an awful lot of different elements, and I'm probably not going to touch them all. So that's our visual. You can see it starts to look a bit more complicated when you start to look at just some of the routes to access. I'm not going to go through them step by step, but you can see they're not exactly straightforward. You don't go in a row and get a decision the next day, as we all know. So for many of the decision-making processes, we have things called the QALY and the ISA. How many of you are familiar with these terms? Anyone? And how many have vaguely heard them but really don't have much idea what they mean? That's what I thought, and I completely understand. Well, we throw them out as decision makers. When I was at NICE, we just constantly refer to these acronyms, and no one really understands what they mean. So a QALY is what is known as one QALY is 1 year of perfect health. No colds, no backache, no anything. 1 year of perfect health is one QALY. And most of us, most of the time, do not get one QALY. The incremental cost-effectiveness ratio, so that is the ISA, which is at the core of NICE's decision-making. And that is basically what's the cost you would have to pay for this treatment to get that 1 year of perfect health. And it's really that simple. There's lots of complicated ways they come up with these figures, but that's basically what they're trying to measure. And I've put up here just some examples of an ISA, the cost effectiveness of different interventions. So smoking cessation, just a couple of £100. Passenger side airbags, it doesn't have to be healthcare interventions, $61,000 to get one quality adjusted life year. And we move through to slightly more expensive end of the spectrum where we get to the ultra rare conditions where we have Cerezyme, rough estimates of between 380 476,000 pounds for that one quality adjusted life year. So I'm going to run through now some of the two of the programmes at NICE and then talk a little bit about some of the NHS England programmes and some of the changes that we're seeing at the moment. So some of this might be familiar. Basic NICE technology appraisal, single technology assessment, 20 to 30,000 pounds ISA, so we just talked about that, cost for one quality adjusted life year, 1 year of perfect health. But there are some variations, end of life criteria for those of you working in field where, largely cancer, where you're looking at drugs that are at the end of life. There are special considerations there. The Cancer Drugs Fund that has gone through a number of changes over the years but seems here to stay at least for a while longer. And patient access schemes, so these are essentially confidential discounts, confidential negotiations with companies. And there's also been some new interventions this year. We have managed access agreements that are starting to come through. I think we're going to hear a bit more of those later from Lindsay, so that'll be great. We've got a £20 million affordability test. So what does that mean? It means that cost effectiveness is not enough anymore. When I said before that payers and HTA bodies are coming together, asking the same kinds of questions, it's exactly where this comes in. They're also asking, now, is it affordable? So if in any one of the first 3 years of a new treatment, it costs in total 20 million, more negotiations will be had, a phasing, a staggering of introduction will be had. So getting the right ISA value is no longer enough to get you reimbursed automatically. There's a fast-track appraisal system for those products that should be particularly cost-effective and coming soon. We've just closed, I think last week there was a consultation, NICE closed, looking at trying to build capacity within the technology appraisal. We'll actually have potentially some quite fundamental changes to how they run, how they work. So a bigger role for the NICE technical team, so for the staff rather than for the committee. Less patient attendance, clinical attendance at committee meetings. So those of you who, I don't know what that happened now. Okay, it's gone. So for those of you who've had any experience of NICE, certainly of highly specialised technologies that Lindsay can attest to, the patient voice is really there, they're in the room and there's an opportunity to speak and answer questions. It could be done better, but they're there. The changes for the technology appraisal system would mean they might not necessarily be in the room. Now that could be seen as an incredibly negative thing, or if the documents to be believed, the proposals are to be... Sorry.
I'm not hearing very
Oh, sorry, if I've gone too far away from the microphone. That's much better, isn't it? I'm so sorry.
Thanks.
Just pretend I was saying really good stuff. It'll be fine. I sound much louder now. Sorry about that. So the attendance at committees. So the idea is that was proposed, that was consulted on, is that if everything's sorted out and there are no further questions from a written submission, patients would not be asked to attend the meeting. So we'll see what the consultation does. It's obviously quite a big change. The idea is if they're not all settled and all questions not answered, they would still come to the meeting. So I think there's definitely a lot to watch. I don't know if Nick's going to say anything about the consultation and the potential impacts of that, but he might now. And also changes to consultation, so speeding up the consultation on the outcomes of those. And then we have the highly specialised technologies programme, which is the programme I ran at NICE, where there were multiple criteria taken into account, so not just focusing on that quality, on that ISA threshold. In fact, there was no ISA threshold. There was an industry submission, academic critique, but the patient input, the clinical input were absolutely key in decision making. They supplemented where there were evidence gaps, really crucial. There were patient access schemes, managed access agreements, as we'll hear later. But very limited capacity, only 3 products a year were put through that, which is a major challenge. There have been changes there too. There's now an ISA threshold. So that's that target figure. What's it going to cost for that 1 year of perfect health? And a 20 million affordability test that we talked about before. And now I've lost the slide. The ISA threshold is set at £100,000, which is a sliding scale. So if you're really, really effective and can get 30 years of perfect health after discounting, which is a technical thing you don't need to dwell on today, it gives all of us headaches. But basically, if you're really, really effective, you could get up to £300,000 for that 1 year of perfect health. If you're not so effective, you could get up to £100,000 for that 1 year of perfect health in this very small programme for a very small number of drugs for very rare conditions. So for most people, most products in rare diseases, this will not apply, this programme will not apply. And we hear a lot about it. I've spent many years talking about it. I earn a living because of that. But it's not the answer to everything. There are numerous other programmes at NICE that don't carry that funding mandate. So people are less aware of them, but they can provide guidance to the NHS. Sometimes it's followed, sometimes it's not, but it can be a lever to get access. Clinical guidelines, medical technologies, a new programme that's just published its first piece, antimicrobial prescribing advice. But I think the impact of this is very varied. So now NHS England. Okay, so if NICE approves something through technology appraisal, through highly specialised technologies, your funding ought to be sorted. Access ought to happen. If it's not happening, there should be routes to address that. But that is what is meant to happen. That is what the NHS is told they have to fund these things. Affordability tests aside. But if NICE doesn't look at a treatment, if it's an off-label prescribing, so it's an existing drug that someone is wanting to try in your disease area because they think it might have some benefit, it's not actually licensed for that. If it's a product that NICE just did not look at, then NHS England, typically for rare diseases, will kick in. And again, there are a number of routes. Your standard route through the normal specialised commissioning route, your clinical priorities advisory group, quite a structured process, quite a long process. And am I right thinking you'll talk more about that, Nick? A little bit.
Just a little bit.
Just a tiny bit, yeah. I mean, in essence, they're all asking the same questions, and they're complicated routes, and they change every 5 minutes, it seems. So, not easy to give you a snapshot of exactly what that feels like. But some of you may go through that route, and it involves working very closely with clinicians, building a case. NICE would have some input. Decisions are taken according to some criteria of NHS England, but they're weighing everything up together within specialised. So they're not looking necessarily just at something that's value on its own, but at weighing up all the things that they're trying to commission or they're trying to pay for and prioritising within that. There are other routes to funding. We have urgent policy statements, critically urgent statements, where if there's a small cohort, there's a long wait for commissioning policy to be developed, there's no NICE appraisal, a small cohort with very urgent clinical need, there's a potential there to have a policy. There's individual funding requests, where we're talking about one individual, so a clinician and a patient say we need access to this treatment, where you have to prove exceptionality. As soon as there's enough of you to form a cohort, a group of patients with the same needs, you're no longer exceptional, the individual funding requests can't work. We have commissioning through evaluation. We have a number of other pathways that are being introduced. We have early access to medicines, which is what would happen before you get a license, where the company wouldn't be reimbursed for a product, but a small number of patients would be able to access it ahead of a decision from NICE with the expectation of data collection. So that is a lot of different routes. I've not even covered them all, and it's really confusing. It's really confusing. As a patient organisation, how do you know where a potentially exciting new treatment might end up? How do you help guide a patient who comes to you, a person living with an illness, and says, I can't access this treatment? And unfortunately, it's not as straightforward as I think we would all like. I think the mess in Nick's presentation title is absolutely right. That doesn't mean there's nothing can be done. This is a number of elements where actually patients, patient groups can input, can make a difference, can make decision-making easier. So we have right back at trial design. And some of you have been involved in that even before there's a clinical trial, working with companies, talking or developing your own trial programs, and saying, actually, let's build this to think about access, let's build this to measure what's actually going to be important to the NHS, what's actually going to be important to getting access down the line, not just getting that licence. Let's measure quality of life. Let's make sure we can present the best possible case and get the best chance of a fast and appropriate reimbursement. There's scientific advice with the European Medicines Agency. For now, they're leaving, they're going to Amsterdam, we heard this week, so who knows exactly what that route will be like in the future. Another question mark. It's great timing, Rick, for doing this talk, isn't it? It's just like, I should have just put one big question mark up, really. We have the HTA processes we've talked about before, and the other reimbursement processes. So I wanted to just leave you, heading into Nick's presentation, with a few thoughts on what I suppose I've seen working and making a difference from patient inputs. So we have evidence generation. And this all sounds terribly complex, registries, natural history data, burden of illness studies. These are all inputs into decision making. But actually they're so much better when there's been patient engagement or patient-led, patient group-led. Expert testimonies. It is never too early. If you know that you're working in an area where a product is likely to be coming through or a number of products are coming through, to work with members, get patient testimonies, do surveys, and actually get your data, get your case made on the seriousness of the condition, and understanding of the impact of the condition, so that you can actually build that case for reimbursement and access. There are limited opportunities to get involved in the actual decision making. You might be asked to attend committee meetings or actually to participate and be members of different groups that are making decisions overall. And then there's a focus on improving the process. Lobbying for change, what does that mean? There's more targeted lobbying, can be incredibly effective, some more than others. I'm sure Nick's going to talk about that. And participating in consultations. We've just had one close. Can I ask, did anybody know that that had happened? Yeah. One person, one hand and two hands, sorry. Yeah. That isn't helping the community, I think. That actually that was a lost opportunity to have a voice and have a say in process change. Admittedly, it wasn't exactly well publicised, but I think we maybe can think together of some ways to make sure we don't miss those, don't miss the opportunity to have your voice heard. You don't get as many opportunities as you'd like, but let's not miss the ones we do. And then holding organisations to account, challenging, questioning. Again, I'm sure Nick will talk about the all-party parliamentary group and the role that that could potentially play. So that I've given you a really messy version of lots of things, probably raised more questions than answers, but I just want to leave you with the fact that there are things you can do to make it that little bit easier, even within this very complicated, messy scope. Thank you.